have a tendency to find is that people that are limited in their abduction external rotation aren't necessarily really tight in their anterior-inferior glenohumeral ligament, which would restrict that motion. It's more so that they're tight in their posterior capsule and the ball is pre-positioned in an anterior-inferior position, and that's what's restricting what would look like full motion, because they're already partially there because they're so tight posterior, the ball's being pushed anterior-inferior. And what I do to test for my theory and to treat that at the same time is they're in this position, I take them back into external rotation, ow, painful, and I get some muscle guarding and a little bit of tightness. I take them shy of that, I give them some pressure over the anterior-inferior capsule, I take them back into that position, and sure enough they just keep going and going and going. And they go, no, that doesn't hurt nearly as much. Well, that tells me they don't have a true restriction in the anterior-inferior capsule, and I will treat the range of motion like that. I'll have them actively reach back, so I'm doing some neuromuscular re-education. While they're reaching, I'm just guiding them. And when I get to the point where I want to strength train, I can do isometrics, resisted external isometrics, switch, resisted internal isometrics in this position for stabilization to try to get some neuromuscular re-education. And then I'll actually do some manual resisted isotonics as well throughout full range of motion. And what you'll find is these people will get this motion back a lot faster if you help stabilize from the ball coming to anterior-inferior. So truly what you're stretching is the posterior capsule a little bit with this to some degree, whereas if you're just cranking on the shoulder in this position trying to get it and make them even more loose anterior-inferior, and you never address the true restriction. And just roll. This is going to be a bursal mobilization technique that I learned at a course where this person's restricted in internal and external rotation after being impinged long enough and enough inflammation, and more inflammation, and it comes in, more inflammation. That burst is starting to scar down to the AC joint, to the rotator cuff, that kind of thing, and they don't like going into this at all. Sometimes what you can get is if you distract them, they can go quite a bit further, or at least with less pain. And you can go through this active internal and external rotation. They're actively doing it, and then I'm giving a little bit of an end range stretch, but I'm distracting the humerus the whole time. If I truly wanted to get a pure distraction, I would stabilize the scapula with this hand and pull with this, but I find I end up squeezing the crud out of my patient's elbows and it kind of hurts. But that is a good technique to utilize. So a lot of times I'll strap the scapula down for this technique, purchase more of the arm, it's more comfortable for the patient, get a better mobilization, and I don't get that whole shoulder blade coming down because the scapula is strapped in. So let's do the scapular strapping technique next. Sit up, please. No subject in mind. Since this is on film.
My bad.
Well, it's going to be on film. It wasn't showing very much.
Whatever.
I didn't want you going, oh my gosh!
Oh my
I can't believe you let me film like that.
I'm sure that I just look off from the back anyway, so it's okay.
Gorgeous.
Yeah.
Okay. I'm ready.
So this is a scapular stabilizing technique to help keep the scapula from moving while you're mobilizing the glenohumeral joint. So go ahead and tuck your arm through here. I'm going to come across like that. I'm actually going to crisscross, trying to lock that down. Okay? Now go ahead and lay down. When she lays down, I'm going to come around the corner of the table. So essentially I've done kind of this figure 8 thing around the scapula. I pull it nice and snug. On tables like this, if you try to pull it too snug, and this isn't perfectly flat, it'll just pull the head of the table up. So try to get the head of the table perfectly flat, or flip your patient around even better. Okay? I'll double up the belt under the arm so I have more of a precise ridge that it's pulling over. It's not this wide belt, and I'll usually put a washcloth under there to pad it a little bit, but to keep it somewhat of a thin line. I'll scoop my patient down into position to tighten that up nice and tight. And then I can take my patient up into their elevation, just shy of their restriction, and I can work some joint mobilizations and then inferior. I can help support the belt in that, working that anterior-inferior mobilization that we talked about, posterior-inferior, straight-inferior, okay? I can work my posterior, put a wedge under there, put the blue wedge under there with it. Your pillow's in the way. Stabilize. I can work my posterior joint mobilization, okay? I can work a posterior inferior joint mobilization. I can do distraction technique through this, so I'm not pulling on the cervical plexus. I'll tip their head this way. I'll grab above the elbow, and I can distract their arm in this position to help get a nice inferior glide. Several techniques I can do for this. You can do your bursal mob in this position with their active internal external rotation. That scapula is not going to come down any further than what it's already belted at, so I can get a good bursal mob with that. Again, a distraction mob. I can get another belt, put it around, and work my inferior lateral mob as well. So it's a good technique to stabilize the scapula for multiple mobilization techniques.
Okay.
Okay.
Yeah,
so,
I know. I'm the one that gets it.
well, seriously, it does make your shoulder there. This is a mobilization with movement technique where I'm trying to assist in kind of a posterior inferior glide, because this patient has a tendency to ride a little anterior with elevation, and they're getting some impingement. So thumb up, I'll have them go through a scaption range of motion. I'm wrapping around where my hypothenar eminence is on the anterior aspect of the humeral head. My left hand is going to be stabilizing over the scapula, and I can also influence this upward rotation of the scapula with my left hand as I'm pushing posterior and giving a little bit of an active assisted elevation up at the top. So I'll have the person go through active range of motion while I'm pushing posterior and then a little bit posterior inferior, getting upward rotation of the scapula influenced through my left hand, and I'm giving them a little bit of a stretch at end range when they get to the top. And this will wear out your shoulder, so if the patient's a little bit below you, or you're a little bit taller than the patient, that works really good. But what you'll find is after about 15 repetitions of this, they can get a little bit higher after 15 repetitions, retest their active range of motion. If they've gained range of motion, great. Do another set of 15, you're done with that for the day. What you're looking for is a nice significant increase in range of motion or decrease in pain after 15 repetitions.